Welcome back to the evaluation of challenging adrenal masses. This is part 4, and this should be the last part. Now, I left off last time mentioning about metastasis. It's the most common malignant adrenal mass. Variable size and appearance, attenuation values, and enhancement will vary depending on the primary tumor, but there is lots of overlap. The most common sites of origin: lung cancer, breast cancer, renal, and melanoma. Melanoma seems to give the largest mets. Renal cancer, particularly when it's clear cell, the most vascular lesions. Lung and breast are the ones that are the most common. So if you look at this case, on contrast, bilateral adrenal lesions could be adenomas, could be anything. Once you notice the missing right kidney, but also the vascularity of the lesion, you can see the one on the left is more necrotic than the one on the right, but they're both vascular. Classic example of metastatic renal cell carcinoma to the adrenal glands. Again, they can be large lesions or they can be small lesions. This 3 to 4 centimeter range is probably the average we will see. Another case, large mass. Actually, it's hard to tell retroperitoneum from adrenal here. Sometimes, we spoke about that before. But here, very nicely, the kidneys displaced laterally, downward, and upward, and the mass extends down. This ended up, although when you look at it, just say retroperitoneal mass, adenopathy. This ended up being metastatic melanoma. There was adenopathy present, but also a large adrenal mass. Metastatic melanoma to the left adrenal gland. And here it is very nicely on the PET scan. PET can be very helpful in select cases of adrenal lesions. Remember, you can have false positives because you have myelolipomas, which can have brown fat, which can have uptake on PET. Otherwise, PET is typically very good in looking at benign versus malignant lesions. And here you can see it very nicely. Now, what about pheochromocytomas? Theos are really the great mimicker. This was an article by Renu Berry last year talking about the various appearances from cystic to very vascular with invasion to bleeding with rupture, just a whole lot of appearances. It's interesting because when we think about Theos, we always thought about a 2 to 4 centimeter hypervascular lesion in a patient with hypertension. Theos, average age, peak about 40 to 50. Remember, Theos are the 10% rule: 10% multicentric, 10% extraadrenal, 10% are malignant. The extraadrenal's common location, as I'll show you, is organ of Zuckerkandl, but they can occur anywhere from the mediastinum down into the bladder. 90% are sporadic, 10% are part of syndromes. Syndromes we think about: von Hippolindo, MEN type 2, neurofibromatosis type 1, and the Paraganglioma type syndromes. Though we talk about syndromes, though we talk about symptoms, 70% of new cases of surgically proven Theos were detected by serendipity. So yes, we look at history, we look at the patient's history for possible syndromes, we look for hypertension, we look at lab values for metanephrines, but 70% are going to be incidental, which is why incidentalomas are such a challenge. The rule of thinking that incidentalomas are just incidental adenomas definitely is not going to be the case. In this article by Leung, which is a decade old, but still perfectly correct, Theos are considered the great mimicker of adrenal masses. Varied clinical, imaging, and pathologic appearances, making diagnosis somewhat challenging. In our article by Berry, Theos are a rare neuroendocrine tumor arising in the adrenal medulla. They account for elevated blood pressure in a small minority of adults with hypertension, and 90% of the cases are benign. Yet, identification is critical because uncontrolled catecholamine secretion increases the risk of serious cardiovascular complications. Up to 21% of patients are asymptomatic, while others may present with symptoms mistaken for underlying cardiovascular conditions. The classic Theo is oval or round, hypervascular, and heterogeneous enhancing mass. The early intense enhancement is reportedly due to the capillary-rich framework. We talk about the adrenal protocols, how we look at washout values, In this article, we said if venous enhancement exceeds 130, it's most likely a Theo, unless you had a renal cell and it was a Met. But I still say that above 110, you really got to think carefully and just get a metanephrine level just to be certain. Again, arterial phase enhancement of over 110 was 58% sensitive and 100% specific for Theos in one study. So be careful. Theos have the highest heritability among all neuroendocrine tumors, 35 to 40% being hereditary in origin. And again, one of the interesting things, whether it's MEN2 or von Hippolindo, the Theos are often smaller and they're often very vascular, but it's where I typically will see 1 centimeter Theos. In the patients who don't have syndromes, the lesions are typically 3 to 4 cm. Now, CT findings. Calcifications can be seen in about 10% of cases. Vascularity, early phase imaging. We mentioned about the washout value of over 50 or 60%, simulating adenomas. And in the absence of Mets, it's hard to determine whether a Theo is malignant or not. Remember, we said that 10% of Theos are going to be malignant. Just some classic examples. Non-contrast CT, indeterminate adrenal lesion. Look how vascular it is. When you give contrast, that's going to be a Theo, right? Look at the vascularity. Look at small nodes, which are also vascular. Look at some of the feeding vessels. And look how quickly the lesion washes out. Another example, left adrenal mass. What could this be? Size-wise, could it be a Met? Could it be a cancer? Could it be an atypical adenoma? Could it be a Theo? Look how vascular it is, 150 Hounsfield units. Okay, both kidneys are there. This is a Theo. There's no differential diagnosis. Yes, you'll check the lab values, and yes, this will be resected. And yes, you can see how nicely this washed out to 59. If you would have used a washout value as your main determining factor, you would have mistaken this diagnosis. Here's another example. A couple centimeter right adrenal, nothing all that impressive. But look at the enhancement, 280 Hounsfield units. So Theos, we said, typically above 130, maybe above 110, can be necrotic, but can really enhance, reaching 300 Hounsfield units. This one was 280. Just a really nice example of a pheochromocytoma. And again, look at the patient's washout value. Here it is nicely shown again on the cinematic rendering. You can see the mass. Another example. Here's a patient with pancreatic cancer and an incidental right adrenal pheochromocytoma, a left adrenal myelolipoma. So again, when you're looking at other lesions, pancreas to metastasize to the adrenal would be extremely rare. I don't think I've ever seen it. I've seen direct extension by large tumors. So again, Theos can pop up almost anywhere, very nicely shown here. And there again. So look carefully at the adrenal in all cases. And although Theos are typically larger, as in this case, they can be small. It's the vascularity that really gave you the diagnosis. Now we talk about cystic Theos. Look at the left adrenal here. It's large. They're stranding by the kidney. Maybe it bled. It's a cystic pheochromocytoma. Very nicely shown there on the volume rendered views and on the cinematic rendered views, which really accentuates the patient's central necrosis. Nicely shown there. Okay? Very good example of a cystic Theo. Another example, large cystic lesion, some rim thickening, some peripheral puddling. Could it be a Met? Yes. Could it be an adenoma that bled? Yes. Could it be an ACC? I guess the answer is yes. This ended up high metanephrines. This was a cystic Theo. This is one of the better examples of how the lesion, 90% of this lesion is cystic. What about this case? A patient was being evaluated for the lung nodule, which is very vascular, and there's a large necrotic vascular right adrenal lesion. The rim is enhancing, the center is necrotic. This was a pheochromocytoma, a very vascular, peripheral, very central necrotic pheochromocytoma. Look at that neovascularity. So you can see with cystic Theos, Sometimes the rim is thickened with mild enhancement. Sometimes it's thickened with significant enhancement. And this was a great case because the met to the lung, it was a malignant Theo, was also very vascular. Here on venous phase, the central necrosis, again, very nicely shown. A really, really nice example of a classic cystic Theo. If I showed you this case and you said adrenal cortical carcinoma, looking at the adrenal only, it would be hard to say that you're wrong. Again, the overlap is significant of a cystic Theo. Now, as Theos enlarge, the masses tend to undergo ischemia and necrosis, which accounts for central degeneration and fibrosis, reflected as heterogeneous enhancement. But I do want to make the point that even smaller Theos can be cystic. A cystic Theo can be distinguished from other cystic adrenal masses due to variable degrees of complexity, such as a thickened wall. In contradistinction, adrenal pseudocysts resulting from prior hemorrhage demonstrate a thin uniform wall that can be calcified. Again, there's overlap, but lab values will often make the difference and make the diagnosis very simple. Between 22 and 97% of Theos demonstrate cystic and necrotic change. So again, when you see cystic lesions, think about pheochromocytoma, look at the vascularity, and again, lab values can be very helpful in this scenario. We spoke before about hemorrhage. Hemorrhage is a rare complication in adrenal lesions in general, but Theos are the most common primary tumor to hemorrhage. The underlying reason we spoke about before is not definitely known, but again, pheochromocytoma can present with a catecholamine release, which can be life-threatening to patients from ruptured Theos due to bleeding. So again, Theos will bleed. Now, perform biochemical evaluation for adrenal masses under 4 cm with cystic and or necrotic change and hyperenhancement, even if the absolute washout is over 60%, because these features are common in Theos. Look for a thickened rind of enhancing soft tissue to distinguish a cyst from cystic and or necrotic change. So again, I think one of the points we made early on, or we questioned, what's the role of lab values? We don't need lab values in every patient, but in cases that are difficult, these cystic cases, and this pearl is very helpful, just get the lab values. It'll allow you to be very specific in the diagnosis. We mentioned Theos 10% are bilateral. Here's a case of bilateral involvement in a patient with von Hippolindo. You can see the enhancement up to 218 on the right and up to 313 on the left. They're not large, but they're bilateral, and this was von Hippolindo. So again, think about the syndromes when you see bilateral adrenal hypervascular lesions. Also, of course, think about renal cell carcinoma. But this was von Hippolindo. And again, as I mentioned, the cases with syndromes, that's 10% of the cases, so it's the less common. But again, if you have a known syndrome, think about that possibility. Again, just a few more images showing you this. It's a case I really like and showed you a lot of images of. And again, the washout, pretty impressive washout. As we look at extraadrenal paragangliomas, which are pheochromocytomas, they can be almost anywhere: carotid bodies, jugular foramen, AP window region, posterior mediastinum, periaortic region, almost simulating an adrenal, organ of Zuckerkandl, and in the pelvis, including the bladder. This is the classic organ of Zuckerkandl at the aortic bifurcation. Just a very nice example. Paraganglioma, extraadrenal pheochromocytoma, that is. Here's a patient who's hypertensive, rule out dissection. The adrenals look okay. Maybe there's an adenoma or something small in the left adrenal. The aorta looks good, but there's a lesion in the bladder. Yes, in most cases, a bladder mass is bladder cancer. No ifs, ands, or buts. But when you're hypertensive and the lesion is bright, you got to think about a Theo, and this was a Theo. Yes, bladder cancers typically enhance. There is going to be overlap, but the clinical history makes you rule out a Theo, and this was a Theo. Just a beautiful example on the coronal volume rendered views as well. So think about that possibility. One of the other classic histories, when the patient urinates, they faint because they get catecholamine release. So it's unusual, but we see a couple of cases every year or every 2 years. Just a nice example, really good example. And here's just another example, paraganglioma. Now, looking at the future, what do we see? Can we do better with AI? Can things like AI and deep learning help us be more specific in terms of looking at the feature? Radiomics, can that be helpful? There are some preliminary work suggesting it could be helpful, but we need more work to be done in this regard. A good article by Glaser a couple years back, Adrenal Protocol, CT is the modality of choice for evaluating adrenal masses, as it can characterize a nodule using both density measurements and contrast washout. An Adrenal Protocol CT consists of a non-contrast scan followed by, if the lesion is over 10 Hounsfield units, then injection of IV contrast, typically 100 to 110 cc's of Omni 350, and then image at 60 to 70 seconds and 15 minutes to calculate washout value. And that's a very, very accurate process, again, remembering some of the pitfalls of washout values. Glaser also says when an incidental adrenal mass is discovered at imaging, 3 important items to consider are a history of malignancy, presence of prior imaging, see if it was there before, and symptoms of a hyperfunctioning mass, as this will guide subsequent management. First, if the patient has a history of malignancy, then an incidental mass has a higher chance of being metastasis, but it's still only 26 to 36%, still likely benign. Second, if prior imaging is available, greater than 1 year of stability is typically indicative of benign lesions. Remember, a benign lesion can grow under 3 millimeters a year. And third, if the patient presents with signs and symptoms of hyperfunction, including hypertension or Cushing's, this is suggestive of biochemically active neoplasm that would require further evaluation. So some very good takeaway messages in that. And with that, that's the end of the 4th part of our look at the adrenal masses, looking at some of the challenges. Again, it's important to know the rules and know there are exceptions to the rules. And I think if you follow the rules, you do really well. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.